Can I just check what time do you want us to finish talking?
Say quarter to, I don't know how long is the presentation, how long did you time it?
We have a time.
But even if well, it depends on how long, because normally we say quarter to 7, 10 to 7. Some people go up to 7 o'clock, which after 7 o'clock, people just get edgy. And we try to finish not later than 7:15.
Okay.
Yeah,
okay,
sure.
Dr. Turner, you can just upload your screen at the moment.
So should we start, Kama? And then are we ready, Kama?
Yes, Doc. Yes.
Okay, thanks. Thank you very much. Good evening, colleagues. Thank you for joining us once for this clinics webinars that we hold every Thursday. And we've been doing this for the last talk. It's now the end of the year, but it's since mid-2020, just after lockdown and the pandemic. And because of you that you kept on attending these webinars, we haven't stopped, and we hope to continue even to the next year. And we just want to appreciate you for making time to come and join these webinars. And as usual, these webinars are CPD accredited. And so we request that when you register, you just give us your full details and indicate your name, surname, and email address, and also your registration number with the HPCSA, the Pharmacy Council, the Nursing Council, and or the Allied Health Professions Council. And after the webinar, we'll upload your CPD points and the registration details, and they'll go to the relevant authority, and then we'll get your CPD points sent to you to the HPCSA or Nursing Council, whatever body it is that's relevant. And please you don't have to give us your details now on the chat box. We've got the details, and there have been some people who've been complaining that they are not getting the CPD points, but we are in liaison with the HPCSA so that we can assist you wherever it is. When there's a problem, just send your information to webinars@clinics.co.za. And this evening, in recognition of World AIDS Day, which is on the 1st of December, we are having two special guests who are going to be talking about HIV/AIDS in adults and in children. And we are delighted that they've agreed to come and talk to us, and they'll be sharing the presentation. First, we have Dr. Julia Turner, who's a medical doctor and a senior technical advisor for HIV and for treatment for right to care, based in Joburg. And she's also on the South African National Third Line RT Committee and National Guidelines Committee, and also the HIV Clinicians Society. She's also passionate about training healthcare workers and has provided HIV and COVID-related training throughout South Africa and in many other African countries. And her areas of interest include healthcare worker, education and pediatric and adult HIV management and HIV resistance. She's got a qualification as a medical doctor from UCT and also Masters in Public Health from the University of Western Cape, and also diploma in HIV management, and also completing the postgraduate studies at Wits University in health, so sciences education. And alongside is what well-experienced Dr. Leon Levine, who's a pediatrician, has been treating HIV/AIDS for more than 27 years, and has been also with Right to Care since 2008, and is currently the chief technical specialist at Right to Care. And he's also a pediatrician by qualification, also HIV medical advisor to one of the larger South African medical aids. He has given numerous lectures on HIV resistance, and he's also has now gone back to private practice, but also associated with the Nelson Mandela Children's Hospital. We'll be having focusing on infants, children, adolescent with HIV and adolescent disclosure. Qualified vets, MSHB, pediatrician, fellowship at the College of Pediatricians, and also DTMNH. And so they'll be talking to us about the essential HIV update for all clinicians. As we ask you to join us for a whirlwind tour with the past, present, and future of HIV management for adults and children. So we'll first have Dr. Julia Turner talking to us, and later on we'll have Dr. Levine, and then later on Dr. Turner will join us here. Thank you very much for joining us, and colleagues, thank you very much for joining us, and we'll have doctors talking to us this evening. Thank you very much.
Thank you very much. It's an honor to be here with you today. Thank you for inviting us. As you said, we will be taking you through a whirlwind tour of HIV management, the past, the present, and the future. So we're looking at where have we come from, where are we now, and where are we going? And we're going to touch on general HIV management, the treatment, PMTCT, and prevention. Sorry. Sorry about that. I don't know what happened.
Maybe Kam will help you how to move to the next slide. Kam, would you just help?
Hi, Doc. Try clicking anywhere on the screen and then navigate.
Is that fine?
Yeah, we can see this full slide. Maybe as Kamu said, you can click anywhere on the slide and just click.
Hi, Doc. Is the slide not moving?
No.
Just click anywhere. Click anywhere and then try moving down, shifting down the slide.
Share. Sorry about that.
All right, I think it's working fine now.
Yeah, you move to the next slide. It's okay.
I'm having an issue. Okay. Okay, so where have we come from? We've come from a place where HIV was a death sentence. But now people living with HIV have completely normal life expectancy. Here's a photo of a 100-year-old man. And we've even had 2 patients cured from HIV, although it wasn't through the best means. But in future, we are still hopeful for vaccine and an HIV cure. But in the meantime, our treatment is so good that it can be as if people don't have HIV when they are taking their treatment. So we've gone from a place of having no treatment. Then we only started ARVs when the CD4 count was very low. We waited for them to basically become ill before giving them treatment. Then we started universal test and treat, saying everyone with HIV should be started on ARVs. And then we started same-day initiation, where we said the very same day they tested for HIV, they should start on ARVs. And only defer for particular reasons. Our HIV regimens have come from a place of, again, having no treatment whatsoever. We then discovered AZT worked quite a bit in 1987, but it very quickly developed resistance. Then we realized that triple therapy worked better. Then we turned to fixed dose combinations to reduce the pill burdens. We were still, at the beginning, we had lots of horrible tablets, many pills. Then we moved on to TEE, which was 1 fixed dose combination in 2013. And now we have, we developed increasing resistance to the efavirenz. And we had a second line PI-based regimens. So we had to move on to dolutegravir. So we gave our TLD, since 2019 has been our first line treatment in the government. And dolutegravir is wonderful because it's once daily, it has few side effects, it has fewer drug interactions, it's affordable, and it has a high genetic barrier to resistance. And that's probably the most important factor. So this graph here shows potency on the y-axis against genetic barrier to resistance on the x-axis, and you can see that drugs like dolutegravir, lopinavir ritonavir, and darunavir ritonavir have a high potency and a high genetic barrier to resistance. Whereas nevirapine, 3TC, abacavir has lower potency and low genetic barrier to resistance. So they become resistant very easily, whereas it takes HIV a long time to develop resistance to dolutegravir and the PIs. Does dolutegravir cause neural tube defects? Sure, you will have all heard of this. The answer now is no. Initially, the Tsepamo study showed a possible increased risk of neural tube defects, but now the completed Tsepamo study, as well as all other studies, have shown no statistically significant increased incidence of neural tube defects on dolutegravir. So it is not something we need to worry about at all. Does dolutegravir cause weight gain? I'm sure many of you have heard of the ADVANCE trial, which was performed here in South Africa. It showed that those on TEE in the green line, over 96 weeks, they gained on average 3 kgs. This is in Black women. The males had less of a weight increase, but in Black women, on average, it was 3 kgs. But those on TLD, over 96 weeks, gained on average 5 kgs. And those on TAF with FTC dolutegravir in the red line gained on average 10 kgs in this time. This was alarming to everyone, and since then it's been looked at in more detail. Leon will talk about the TAF association with weight gain later, but for now I want to tell you that regarding dolutegravir and weight gain, repeat studies of the same data have shown that it wasn't actually the dolutegravir causing people to gain weight, but it was actually toxic levels of efavirenz that prevented people from gaining weight. Now, the next question is, should HIV treatment always involve 3 ARVs? We always used to say yes. Can you switch from TEE to TLD if a patient has a high viral load? So let's look at these. Switching regimens. Where have we come from? We used to say never switch one drug in a failing regimen. You need 2 fully active second ARVs before you switch one drug. But then the EARNEST study showed that when switching to a PI, you can actually recycle 2 resistant NRTIs and the patient will suppress fine. Then the NADIA study showed that you can do the same with dolutegravir. When you switch to dolutegravir, you can recycle resistant tenofovir and emtricitabine or lamivudine. But we don't know if the NADIA study applies to abacavir. It only applies to tenofovir. We suspect that it might not apply quite as well to abacavir, that some patients might develop resistance in that instance. And then we've also since had studies on dual therapy showing that dolutegravir can be given with 1 fully active ARV, such as 3TC or rilpivirine. What we don't know is whether dolutegravir can be given with a partially active second drug, like 3TC or rilpivirine. What we do know is that dolutegravir monotherapy does not work. So that was shown very clearly in the Domino and the Mon case study, so we don't really want to test that out yet. Definitely not on your patients. We've got 2 new guidelines this year, our Department of Health guideline, as well as our Southern African HIV Clinician Society guidelines, and they cover all of these changes that I'm talking about today. So if you haven't read them, those of you who work in the government sector, please read the NDOH guidelines, and those who work in the private sector, please read the Clinician Society guidelines, and then both of you should read the other one as well, because actually these 2 guidelines work really well together and both bring out some slightly different aspects of HIV management that are both really important, and they are quite well aligned because they were actually developed by a lot of the same experts, such as Jeremy Nell, and we wanted it to be quite a seamless transition for patients who move between private and government sector, as we know that that happens quite rapidly. So looking at treatment optimization, what do these new guidelines say? They say that patients on TEE can now switch to TLD regardless of viral load, whether it's high, whether it's low, or even if they don't have a viral load taken at all. They can switch. And this is preferable because TLD has been proven to have better outcomes than TEE. Patients with renal failure on abacavir 3TC efavirenz can also switch to abacavir 3TC DTG regardless of viral load. As we said, it's not 100% proven that they won't develop resistance, but in the guidelines we are saying that they can still do this. We will just keep an eye on them and monitor them well. And then patients on a PI-based regimen, if the viral load is less than 1,000, they can also be switched to TLD, which is often preferred as it's less tablets once a day. If they have a viral load over 1,000, however, then you need to follow the table. This is from the NDOH guideline, which then looks at whether the patient was adherent or not, and then decides if they must do a resistance test or not. In the private sector, we can have a lower threshold for doing a resistance test because finance is not such an issue. Then the option of dual therapy, which might be new for some of you, is that we can initiate patients on just dolutegravir and 3TC, but it has to be specific patients. This was shown in the Gemini 1 and 2 trials, but it has to be patients with a viral load less than 500,000, CD4 count over 200. They can't have hepatitis B or TB. It must be a true initiation and ideally be someone who will have good adherence. So just remember that it's specific patients. And then in the same way, specific select patients can switch to a dual therapy regimen, such as dolutegravir 3TC or dolutegravir rilpivirine. But please read the guidelines, the Clinician Society guidelines, for more information on this. It's definitely not for anyone. Where are we going in the future? We've got injectables. Cabotegravir rilpivirine is one of our injectable options where you take 2 injections every 2 months. And this is shown to really improve adherence, and patients seem to really enjoy it. 91% of patients preferred the long-acting therapy despite injection site reactions. But these patients have to be virally suppressed, and they have to have no history of virological failure. And because many of our patients have been on efavirenz before, they might have resistance to rilpivirine, so this then won't be an option for them. Rilpivirine actually isn't such a strong ARV, and it is causing some resistance. So this isn't necessarily the ideal combination of injectables, but it is just showing you that there are injectable options, and in the future, we will have even better long-acting options, because there are studies being done on islatravir, which is an NRTTI. It's a small tablet you can take daily, weekly, or even monthly, one small tablet a month. Or a drug like lenacapavir, which is a capsid inhibitor, and this will potentially be a 6-month subcutaneous injection. So these might be better combinations with the cabotegravir for a long-acting option. And we are ideally hoping that maybe we'll get an option that will be 2 injections every 6 months, something like that. Will be incredible. Now I'll hand over to Leon to give us a brief update on the pediatric ART.
Thanks, Julia, and thank you for inviting me to speak. Next slide, please. So first I want to talk about some fantastic new pediatric formulations which have really revolutionized the treatment of children. We go next slide, please, Julia. So first of all, the Bacaba 3TC combination. So we've had a Bacaba 3TC combination for adults and older children, the 600, 300. This is the 120/60. They are dispersible, scored, can be used from 3 kilos to 25 kilos, literally going to replace all the other Bacaba 3TC formulations. At 25 kilos, you can then use the adult formulation, 600, 300. Can be swallowed, chewed, crushed, or dissolved in water, given once a day. There's 2 generics registered. It's available both in private and in the DOH, and it's actually more cost effective than the existing formulations. Next. Then the wonder drug everybody's talking about. We've had this dolutegravir for adults, but now we've got it for children. Up to now, dolutegravir can only be used from 20 kilos. Now we have the dispersible pediatric score dolutegravir tablets. They are can be used from 4 weeks and 3 kilos, must be both, and right up to 20 kilos. At 20 kilos, you can use the adult formulation, 50 milligrams. At 30 kilos, you can use TLD. So literally from 4 weeks and 3 kilos, we can put these children on dolutegravir, which is going to revolutionize this treatment, because up to now they've had lopinavir solution, which tastes absolutely vile, 40% proof alcohol, and really the kids did not tolerate it. So this formulation can be added to water, milk, or soft foods, can be swallowed whole, but not chewed or crushed. Available both in private and DOH. The interesting thing is not bioequivalent with our existing dolutegravir 50 milligram. So it's a factor of 1.6. So 30 milligrams of the dispersible is the same as the old 50 milligrams film-coated tablet. So 30 times 1.6 gives you 48. So that's where you get that conversion. So you can't switch from this. You can't say from 50 milligrams of the old tablet to 50 milligrams of the dispersible. No, 50 milligrams of the old tablet gives you 30 milligrams of the dispersible. So very important to be aware of that. As in adults, if with TB treatment, you have to give the dose twice daily while they're on TB treatment. And generally, when they get to 20 kilos, you can change them from the pediatric formulation to the dolutegravir 50 milligrams, unless they are struggling to swallow tablets. Next slide, please, Julia. Okay, then this is an interesting formulation of what we call the 4-in-1, okay, which is Bacaba 3TC lopinavir. The old regimen that the children were on before. It's all together in a capsule, which I open up. It tastes delicious, unlike the old lopinavir, which tastes terrible. It tastes absolutely delicious, and you can use it from 3 months and 3 kilos, sprinkled on breast milk formula, other age-appropriate foods, but it is given twice daily. Can have a limited use in the DOH because it came at the same time as the pediatric dolutegravir. So patients not tolerating dolutegravir and temporarily in patients failing a lopinavir regimen. And it is available both in the private sector and more in the DOH, but it's still slow in the DOH. Next slide, please. As I said, the only real problem with this 4-in-1 is that it came at the same time as the pediatric dolutegravir, and for that reason, it's hardly going to be used because dolutegravir is going to be used. You know, if it had come a bit earlier, before we had dolutegravir, it would have been used. Come a bit later, when people are starting to fail the dolutegravir, it will be used more. So its time will come, the 4-in-1. We will use it when patients stop tolerating dolutegravir or start to fail the dolutegravir. Next, please. Another formulation I want to talk about is TAF. We just spoke a bit about it in the advanced trial. So it's a prodrug of tenofovir, just like TDF. TDF is also a prodrug of tenofovir. This has less effects on the kidneys and the bones. It's a very small formulation. The dosing differs depending on what you give it with. If you give it with ritonavir, then it's 10 milligrams a day, once a day. And if you give it with not with ritonavir, it's going to be 25 milligrams once a day. So we don't have the 25 with the 10 milligram, only the 25 milligram. And it can be given from 25 kilos. And because it's better on the kidneys, can be used in the EGFR above 30. So whereas you wouldn't use tenofovir below 50, you can use TAF from 30. But it has been associated with weight gain. Next slide, please. In this trial, which was a continuation of the advanced trial, but much smaller numbers, you can see that TAF1, top one in red, the weight gain is much more than TLD, which is the green one, and much more than the TE, which was the brown one. So when they switched them all back to tenofovir, you can see the weight, the red one, went back down to the TLD curve. So in these patients who don't have renal dysfunction, young children from 25 kilos, if you're starting on TAF, we can then switch them to TLD when they get to 30 kilos. And if they've gained any weight, they will then lose that weight. So we're not too worried about the weight gain in this situation. If you get them off their TAF, they will lose the weight and go back to where they would have been had they been on TLD. Next, please. So the formulation we have, there's two formulations in the country. There's TAF-Ed, which is TAF FTC and dolutegravir, and TAF 3TC and dolutegravir. They're similar, but the TAF-Ed is cheaper, so most people are going to be using it, and unless you're getting side effects from the enterocytobine, in which case you'll change to the other one. So it's a tiny tablet, the children love it. Can be used from 25 kilos. Remember, TLD only from 30 kilos. So in your younger kids, you can use it. Still need to monitor renal function and weight gain. At 30 kilos, we can then change to TLD. And it's available in the private sector, and we're hoping to get available for selected patients in the DOH. And the interesting thing is that in all the studies, the men don't seem to gain weight on it, but the women do. And that's been my experience as well. Next, please. Okay. So this is the famous dosing chart. The DOH dosing chart's got all the new formulations on it except for TAF. So it's all there. It's downloadable from the Clinicians Society website. I'll try and see if I can get the link and put it in the chat. And all the doses are there, and it makes it very easy to prescribe these new formulations. Next slide, please. Okay, so that's the new formulation of drugs. So in terms of the pediatric guidelines, the principles on which the guidelines are based, very similar to adults, is two things. The NADIA trial, which showed that you can use TLD after TEE. And number two, if you can't rely on the NADIA, making sure you've got a backup PI regimen. So let's look quickly at the guidelines. We don't have much time. Next. So this is what the guidelines say. First line, if it's a child, a neonate between 2 and 3 kilos, they're going to get AZT, 3TC, and nevirapine, and that's the same as before. Then at 3 kilos and 4 weeks of age, they will then change to the dolutegravir, abacavir 3TC, pediatric dolutegravir. Ideally, you want to be using the abacavir 3TC combination, so it's going to be a once daily regimen, fantastic, well tolerated compared to the old one which we had before, which was very poorly tolerated. And then you would continue when they get to 20 kilos, you can change from the pediatric dolutegravir to the adult dolutegravir, the 50 milligram. At 30 kilos, they can then go on to TLD. So that's what the DOH guidelines are saying. It would be very similar, except you could use TAF-Ed from 25 kilos. Next slide, please. Julia? No, thanks. So I've got quite time to go through these algorithms, same as in adults. So if the patient, and these are where you would switch a patient even if you haven't got a viral load result or the viral load is higher. If they're on a non-nucleoside regimen or a dolutegravir regimen, they can change to TLD, or in children, we use a backup of 3TC dolutegravir, which we call ALD. Next one. That's based on the Nadia. Next slide. So if they're on a PI regimen for less than 2 years, so if it's less than 2 years, then we know the PI is still active, and so you can then change them to dolutegravir, and if we get it wrong, you can still rely on the PI regimen. If the viral load is above 1,000, okay, then there's a separate algorithm. But if they're on a PI regimen and the viral load is above 1,000, it's a separate algorithm. If the viral load is below 1,000, we know the regimen is working, so we can still change them to dolutegravir. So basically, you can change to dolutegravir patients who are on efavirenz or nevirapine regimens, who are on dolutegravir regimens. They can go on to TLD or ALD, irrespective of the viral load. If they're on a PI regimen, if they have been on for less than 2 years, they can go into TLD or ALD. And if they're on it for more than 2 years, if the viral load is below 1,000, well, then you can change to TLD or ALD. Viral is above 1,000, then you would need to follow this next algorithm. Next slide, please. So this is the algorithm that we have for children. On a PI regimen, I'm not going to go through it. If they're on for less than 2 years or viral load less than 1,000 on the right, they can change to the dolutegravir regimen. If the viral load, if they've been on the PI for more than 2 years, and depending on the adherence, with either do resistance testing or and change them to dolutegravir regimen. And if you're worried that the adherence is because of the poorly tolerated lopinavir regimen, you could put them on the 4-in-1 in the interim, the rectangle in the middle, put them on the 4-in-1 and see if you can suppress the viral load. If you suppress the viral load, you can then go on to a dolutegravir regimen. So basically, these guidelines are trying to get as many people as possible onto a dolutegravir regimen. I know it's a bit complicated with these kind of patients. I would advise you to phone our helpline and we'll help you with them. Next slide, please. Patients who are already on a dolutegravir regimen. So then the guidelines distinguish between if they've ever been on a failed regimen before. If they've never failed a regimen before, we call them TLD1, okay? And those patients in the private sector in the government sector will virtually will never get a resistance test done, because it's very, very unusual to get resistance if it's a first-line dolutegravir regimen. If they're a second-line dolutegravir regimen, then they could get resistance testing if they've been on it for more than 2 years, and you've got to discuss with an expert. I'm not going to go into too much detail, but I would suggest that if you have patients failing a dolutegravir regimen, to discuss it with an expert. Next slide, please. Okay, so what would I suggest for the private sector? Well, there's no pediatric guidelines for the private sector, but based on the government guidelines, which are pretty good, this is what I would recommend. So if you've got a patient, no matter what regimen they're on, you must consider switching them. So you could switch them to the dolutegravir regimen, a backup of 3TC, or TAFED if they're over 25 kilos, or TLD if they're over 30 kilos and over 10 years, under the following circumstances. So when could you switch? So I'm talking about every single patient you have to review and see when can I switch. Next slide, please, Julia. So in private, I would switch any patient who is on a non-nucleoside regimen. You don't even need a viral load. Switch them to the dolutegravir regimen. Any patient who's on a PI regimen with a viral load below 1,000, you switch them to a dolutegravir regimen. You don't have to worry the fact, because the PI is working, you can switch to a PI regimen. Any patient on a PI regimen for less than 2 years, once again, the PI is still going to be working, you change to a dolutegravir regimen. And any patient on an AZD3C or dolutegravir, you could switch them to a dolutegravir. So these are the patients that you would switch to dolutegravir regimens. Next slide shows the ones that you may not necessarily switch. If they're on a PI or a dolutegravir regimen for more than 2 years with 2 high viral loads above 1,000, or drug interactions, then ideally in private, discuss with an expert, and then you probably will require resistance testing. But there's a trick to do resistance testing. If they're not adherent, it will show nothing. So you discuss with the expert who will help you with that. Okay, ask them to adhere for a month and then do resistance testing. You're much more likely to have an accurate test. And remember, in the private sector, you do need to get authorization for medical aids. It's not usually a problem giving it, but if you don't get authorization, unfortunately, the patient ends up paying. And it's like 7,000 Rand. Much easier just to get authorization for the resistance testing, and also they will make sure this gets done properly so you can actually have an accurate test. Next slide, please. Okay, so what I'm saying is that in pediatrics, probably in adults as well, every single patient must be reviewed to change their regimen to a better, well-tolerated regimen. But what about patients who are on third-line regimens? Can we optimize their regimens as well? Definitely. There have been major advances in third-line regimens over the last few years, both adults and pediatrics. Don't use raltegravir anymore. We're using Grunewald once daily in certain situations, and we're changing to TLD, even on its own in third line, or ALD in certain situations. So every patient on the third line needs to be reviewed towards optimizing the regimen, especially if they're viral load suppressed, but even more so if they're not suppressed, because obviously you need to sort them out. But even if the viral is suppressed, you need to optimize the regimen. And I'm advising you to discuss with an expert. Next, please, Julia. So bottom line in pediatrics, we need to review every single pediatric or adolescent HIV patient with a view to optimizing their regimens, irrespective of whether viral loads are suppressed or not. We upgrade our cell phones every few years. Why do we leave our patients on old, horrible, regimens that should have been changed long ago? So bottom line is, and I'm happy to help you on the helpline. If you've got any patient on pediatric regimens, we need to look at and review them for optimization. And I'll hand over to Julia. Thank you.
Okay, thanks so much, Leon. I'll carry on with HIV prevention. So we have done amazingly with our PMTCT. We've decreased the mother-to-child transmission rates from about 40% to less than 2%, which is incredible. How have we done this? And we still need to do more. So how can we do more? I think that this is actually even better done in the government sector than in the private sector. So I'm encouraging all those of you who work in the private sector to pay attention here. We would like planned pregnancies. We would like to give PrEP to HIV negative pregnant and breastfeeding women, because most of our babies who get HIV are actually from ladies who seroconvert or develop HIV during pregnancy or during breastfeeding. So we need to protect those HIV negative pregnant ladies and prevent them getting HIV. We want to do HIV tests 3 to 6 monthly during pregnancy and breastfeeding if there is any potential exposure to HIV, so that we pick them up early and can treat them. We want to ensure good ART and viral load suppression. We want to do a viral load at booking, delivery, and 6 monthly during breastfeeding. We want early infant diagnosis to find out if the baby has HIV. So we do birth testing, 10 weeks, 6-month PCRs, and in government sector, we do a 18-month universal rapid test for every baby, regardless of whether their mother has HIV or not. We want to give infant prophylaxis, which I've listed there and won't go into. And what changed in the guidelines is that we are no longer giving cotrimoxazole to the HIV exposed but uninfected babies. Then other HIV prevention. Where have we come from? We've come from the old ABC, which did not work. And now we have many options. We've got PrEP. We've got oral PrEP, which is 95 to 99% effective if taken. We've got on-demand PrEP for MSM and transgender women, where they only have to take 4 tablets. We've got FTAF as an option. We've got cabotegravir long-acting 2-monthly injections. So 1 injection every 2 months for PrEP. And this works even better than the oral PrEP. We've got dapivirine ring, which is 30% effective. And in future, we're looking at combinations of PrEP with contraception. Which ARVs would you give an adult for post-exposure prophylaxis? I hope you all say TLD. That's definitely the best option for an adult. So remember, PEP is there. It must be given for every day for a month, and it must be started as soon as possible and not later than 72 hours after exposure. Male medical circumcision can decrease your risk of HIV by 60%. So these are all things that I want every clinician to remember. Refer your patients for circumcision, offer them PrEP, offer them HIV testing. U equals U is our most powerful tool we have. It means undetectable equals untransmittable. If a patient is on their ARVs and their viral load is suppressed, they will not transmit HIV to their sexual partners. This is amazing, and this is why we need to find everyone who has got HIV, test them, find them, put them on treatment, and get their viral load suppressed. The U equals U message improves quality of life, it decreases stigma, it can increase testing, improve adherence and viral suppression, and it prevents the spread of HIV. So spread this message. We want everyone to know about U equals U. And this leads us to the 90-90-90 targets, which I hope you're all aware of. They were then changed to 95-95-95 because we achieved the 90-90-90. So they're our United Nations goal for the world. We want 95% of people living with HIV to know their HIV status. We want 95% of them to be on ARVs and 95% of them to have a suppressed viral load. If we achieve this, then people will not get sick or die from AIDS. We will reduce mother-to-child transmission. Our babies won't get infected. We will prevent new HIV infections. We can therefore actually end the HIV epidemic. So where are we now in South Africa? We're at about 90, 91, 94 from our latest SAB SSM 6. Females are doing better than males, and children are unfortunately doing the worst. So we still really need to help our children. And how can we do this? Again, I'm asking all of you as clinicians out there, and to spread this message to all your fellow clinicians, regardless of speciality or where you work. We want to offer testing to all patients. We want to do index testing. So that means all people living with HIV, their children, and their sexual partners need to be offered HIV testing. We can have HIV self-screening where people test themselves. With the second 95, we want universal test and treat. Anyone who tests positive must be started on ARVs on the same day if they don't have medical reason not to. And the second and third 95 refers to retaining the patients in care, not losing them to follow-up, and viral load suppression. So we want active follow-up. Call your patients back if they don't come. We want to give multi-month dispensing so that they don't have to come every month to the pharmacy. We want treatment optimization. TLD is the way to go, and dolutegravir for children, as Leon's mentioned. We want viral load monitoring, and we want lots of patient education and adherence support. So useful tools are the guidelines I've mentioned, the national ones, and the Clinician Society, the HIV and TB helplines. I've put our helpline number up here. You're welcome to phone us anytime. The Liverpool Drug Interaction Checker is a really useful tool. And this is Leon's number for any patients you want to refer to him. So in summary, we want to offer HIV testing to everyone. If they're positive, start ARVs. If they're negative, offer them PrEP to prevent them getting HIV. If they're already on ARVs, we want to optimize their regimen and ensure their viral load is suppressed. We want to educate everyone about U equals U to reduce stigma in the communities. There is no reason for HIV stigma anymore because it is a very normal, very common illness where people can live completely normal, healthy lives to normal life expectancy. So let's be the generation that will end HIV. Thank you very much.
Thanks a lot, Dr. Helen, Dr. Levin, and we really appreciate your time and your sharing of this information. I think you've really taken us the journey of where we are with ARV management, and as we celebrate World AIDS Day tomorrow. And I think it's a good ending also just to talk about prevention. Last year, I think this time we talked about 1990, and now it's amazing that we moved away from that to 95. And we hoping that the figures that show that we are still at 91 and not yet throughout the 95, that we've achieved the target. But I think this is one way of making sure that we support the efforts with these webinars. And all the colleagues who are logged in, we all participate together to reach that target. There are a few questions now. We want to encourage all colleagues who are linked in to also post a few questions for both Julie and Leon. There's a question that has been sent to me directly. The question is, please comment on the injectable efficacy if an abscess and drainage thereof happens. This is from one of the stages. I don't know if you...
Could you just repeat that?
Yeah, please comment on injectable efficacy if an abscess and drainage thereof happens. Suppose that once you've done the injectables and then you end up with an abscess.
The abscess, it becomes infected.
Yeah, so does it show that there's a good efficacy? Yeah.
I actually don't know the answer to that, I'm afraid. I haven't seen a study showing if there's any change in efficacy if an abscess develops.
Okay.
So if I could just add that, I mean, I also don't know the answer, but this is a very interesting phenomenon. If you look at the studies of the injectables, okay, clinicians all said this is terrible, major injection site reactions, nobody's going to want this, and the patient said we love it. They absolutely loved it. And it seems to be, from what we can gather, is that these patients are doing so well, okay, but every time they take their tablets, it's reminding them you are sick. And with the injections, they can have 2 months, they have the injection, they are prepared to go through that pain and injection site reactions and only, be reminded of the disease in 2 months' time. So once again, point to us that you have to ask the patients, because the clinicians said, no, the reactions were not great, but the patients loved it. But I also don't know the answer to the, if they get an abscess, whether it is going to compromise the treatment, and you might need to cover them with something else.
Okay. I'm just wondering, when both of you working in the HIV/AIDS space, with all these new drugs with difficult names, how do you remember them?
It keeps you young, right? It keeps you young.
Keeps you young.
Yes.
Yeah, here's one of them from Dr. Desai. Is the injectable cabotegravir available in South Africa, and can we switch to tell the patients to this if they are virally suppressed? I hope I pronounced the drug properly.
Yeah, I did answer it on the chat, but maybe just want to comment. Is that cabotegravir? It's going to be cabotegravir plus rilpivirine. The cabotegravir on its own is only going to be used for PrEP. The cabotegravir and rilpivirine is not yet available. Julia, if you want to comment on that.
Yeah, no, that's all. And I think we were very excited about cabotegravir rilpivirine, but we are now seeing a bit more resistance occurring with the rilpivirine. So we aren't quite as excited about it as we were. We thought it would possibly be our saving grace, but we actually are hoping for a stronger second drug to accompany the cabotegravir going forward.
Okay.
So we have to wait a bit longer for that.
Yeah.
And also the problem with cabotegravir rilpivirine is that it's very expensive at the moment. It's definitely too expensive to roll out in the public sector.
Is it? Yeah. Thanks for Leon for the pediatric dosage chart. Those colleagues who are logged in, I'll copy it, but if you're able to copy it on your side, I think it's nice to just copy the link and save it on your side, but we'll also share it tomorrow with everyone. The next question is, can you both comment on PMAT, pharmacy-initiated treatment? I think we had some presentation of that a few months back, and there was a pharmacist who were promoting this, and now, there's also NIMAT also. On your comments, I think that there have been some court case on this.
It's a bit of a controversial issue. Leon, do you want to go first?
You go first, Julia.
Okay.
It's an adult issue.
It's another issue.
I've got to grow up about it.
You're a child, you don't talk about adult issues.
I will make a comment, but I need to grow into this a little bit. So Julia must start.
Okay.
Okay, I'll start, sure. So I think the goal is to make ARVs as available and accessible as possible for patients. I think that was what was in mind when PMART was developed, that we want to make it easy for patients. So particularly, I think if someone goes to the pharmacy and wants the morning after pill, they should be able to be given post-exposure prophylaxis as well. So to me, that's probably something that triggered the pharmacist to think, I should be able to dispense this because this patient needs it. And then PrEP as well for prevention, that's another sort of easy thing that perhaps the pharmacist should be able to dispense because we want it to be widely available and easily accessible. When it comes to ART as treatment, once a patient is stable on the ART and they just need repeat scripts, they've had viral load suppression for years, they're doing well, it's hard to argue why should we not encourage a pharmacist to be able to repeat that prescription, as long as the pharmacists have the appropriate training, which I think has been developed, and that was the whole process around it, was to give them the appropriate training so that they know how to manage these patients. I do know that there is an opinion of doctors that they are used to treating these patients and they want to give the patients all the support that they usually do. And I think that is a valid argument for saying, that you want to continue that. I don't have a problem with it as long as the pharmacists are giving as long as they are trained to give the right level of care and support. I think adherence is our biggest problem. So we really want our patients to adhere, and if that means making it easier for them to just be able to go to the pharmacy and get some treatment, then it's probably a good thing.
Okay, thanks for that response. Dr. Mashego wants to know, why is there no dual therapy in the public sector? As it is cost effective and efficacy is high. Is that because of the high hepatitis rates in the low income communities?
Yes, that's a very good question. And yes, that is definitely one of the answers. One of the answers is because of the high hepatitis rates. So that's why we like to keep the tenofovir there, so that tenofovir 3TC can help to treat hepatitis. And I think that's one of the reasons that dual therapy won't anytime soon be our first line treatment in the public sector. And the other thing is just that we don't have the long-term data of durability of dual therapy. So at the moment, TLD is working really well. So it's slightly more risky to change to dual therapy than to just stick to TLD, which is working so well and doesn't really have many side effects anyway.
Yeah, if you could just come in as well. I mean, it's a small thing, but it's going to add to the cost because remember, Julie, you said that the viral load needs to be below 500,000. So we then obviously need to have a baseline viral load, which we're not doing in the state as well. So that's going to add to the cost as well. So some countries are doing. I know Botswana is going for dual, but I don't think we're ready for it for the reasons that you've mentioned.
Yeah, and just because the studies, as I showed there's a few caveats. The studies haven't been long enough and they haven't involved pregnant women, they haven't involved people with TB, so we don't know the answers to those questions. So it just makes it a bit more complicated.
Okay, thank you very much for that. There's a question about this. Most wants to know. The new guidelines talk about VTP and repeat HIV negative for every subsequent visit until delivery and post-delivery. I think this goes with the LPR negative. There's dual testing for both used in the same screening slide. think they just want to say thank you for that, for the presentation. I'm not sure if you have to comment on this.
I'm not sure I totally follow the question, but I think they're talking
It's a
about
comment, yeah, but it's just,
yeah, that you can see in the guidelines that they've combined syphilis screening with HIV testing particularly for pregnant women who are HIV negative. Then they recommend do a combined RPR and HIV test. I think that's what they're referring to.
Yeah, and also talking about doing it, repeating the HIV for every subsequent visit if the moms are negative. I just want to add to that. I mean, I think both in the private and the government sector, if you have a look at PMTCT, I could just make a little brief comment. Our last hurdle with PMTCT is breast milk transmission. Okay, we are pretty good at the transmission at birth is very low. It's under 2%, but it's towards the end of the year it goes up to like something like 5%, and that's because of breast milk. And the breast milk transmission has got two components. The one is obviously the moms who are on ARVs who are not taking the ARVs and their viral load goes up, and that yes, they need to be monitored in the government sector. They would have viral loads done every 6 months. I think in private should be done every 3 months, making sure that the mom's viral load is suppressed. But there's quite a big component of moms who are negative during their pregnancy and seroconvert during pregnancy or breastfeeding. And remember, a patient who's newly seroconverted will have a high viral load and is more likely to transmit to their baby. And so those are the patients who not only will they get HIV, but their babies are at high risk of getting HIV. And those are the ones we want to target for PrEP. If you have got a mom who is a pregnant mom or breastfeeding, they need to be, even though they are negative, they should be given PrEP so that they don't seroconvert during pregnancy. Because what's happening is, unfortunately, I think the men are straying during the last trimester, bringing HIV back into the family. And then not only does the mom get it, but the baby gets it as well. So that a very important group to identify, not only testing and make sure they're negative, but to do something more about it, put them onto PrEP.
Okay. Thanks. You spoke about the UU, and you said it's undetectable, means untransmittable, it won't transmit. So does it mean that if you reach that stage, there is no need for protection?
So that's a very good question and something that everyone grapples with. So how I recommend you explain it to patients is that it means undetectable equals untransmittable, means your viral load has to be undetectable, but not just when you tested your viral load 3 months ago. It has to be undetectable every single day. So it's something that you have to discuss with your partner, and it has to be a joint decision that if the partner chooses to trust that their partner who is taking treatment and had a suppressed viral load, they need to then know that that partner is still taking their ARVs every single day since that viral load was taken. Otherwise, I would recommend protection or PrEP for that partner if they don't think that the person is continuing to take their ARVs. But we always still recommend protection for other sexually transmitted diseases as well as unwanted pregnancies.
If I could just come in there, I agree with Julia that U equals U is a couple's decision. The decision not to use condoms is a couple's decision. Okay, an individual cannot make that decision. Okay, it must be as a couple that they decide. And there are varying degrees of how this decision can take place. You can have a couple who say, you know what, we trust each other. The infected partner trusts the uninfected partner. They're not going to stray outside the relationship and bring back other diseases. The uninfected partner trusts the infected partner that they're going to take the treatment all the time and stay suppressed. And they can then, as a couple, decide we're not going to use condoms. The next step would be they use condoms, but they want to have a baby. So just at the time when the woman can fall pregnant, which is ovulating, they would then not use condoms at that time, relying on U equals U. She can fall pregnant, and then they can carry on using condoms. And the third step beyond that is they want to have a baby, but the uninfected partner is still not comfortable with U equals U and wants to go into PrEP at that time, and that is also acceptable. It's not necessary, but it's also acceptable. So you have to counsel the couple. So this is what it entails. Yes, we've got this fantastic thing, U equals U, but what you do with it is a couple's decision. Okay, it's not something that you say everyone can stop using condoms. No, for sure not. In a relationship, they have to decide what we're going to use with that information. Also remember that U equals U only applies to sexual transmission. Okay, from mother to child transmission, it's not zero. It's very, very low, but it's not zero. There have been documented cases of mother to child transmission with suppressed viral loads, but sexual transmission is absolutely zero. Okay, it's 0, 0, 0. It's not. There's no exceptions.
Okay, that's good. It's good to hear. Yeah, so the trick is that people should continue taking treatment all the time.
Absolutely.
Yeah.
Look, couples can help each other, right? The uninfected partner can help the infected partner, be the treatment buddy, make sure they take the treatment. But the decision not to use condoms is a big decision, and that is a couple's decision.
Mm-hmm. Indeed. I don't see any further questions unless if someone wants to just unmute themselves and ask a question. We are always asked this question, most people, that would you want to share this presentation or not? I know that we've been live on YouTube, and so the presentation, the talk is available on YouTube for anyone who wants to discuss, to go and watch. But are you amenable to sharing this presentation in case there are people who want to go over this? Because they're quite important information that you've shared today.
Yes, sure. I think we should be able to.
No problem.
I'll discuss it with Leon and then we'll get back to you.
Yeah, it shouldn't be a problem. Would you like us to send you, maybe we'll have a look at the slides and send them to you, and then, you can make it available to everybody.
Yeah. Just once you've decided what you want to share, then we can just share.
There may be some slides we don't want to share, but we'll have a look, and it shouldn't be a problem. And I see that Tabo's raised his hand as well.
Yeah. Tabo is our regular. Tabo, Dr. Mashir, can you go ahead?
Hi, how are you?
Fine, sure.
I'm fine. Just a quick one here. I just want to get from the two experts. Yeah? Papers now have shown that in the patient on rifampicin, there's no longer a need to double dose. On the dolutegravir or the DTG. And what is their comment on that?
Are you talking about with TB treatment?
Yeah, the patient with TB treatment, especially rifampicin. Remember the norm is you have to double the dosage of DTG. But papers are now starting to show that actually you don't have to double the dose of DTG. It's still effective on a single dose of 50 milligram.
Yeah. So you're absolutely correct. We thought that it would be a big problem if people didn't double dose the dolutegravir and they took rifampicin-based TB treatment, and then we thought they'd develop resistance to dolutegravir. But the latest study has shown that patients don't really develop resistance to dolutegravir. They haven't decided to change guidelines as yet. But what they've said is that we'll still recommend double dosing, but at least we know that if it doesn't happen for some reason, if the patient doesn't, it's not the end of the world. We thought it was the end of the world that they would develop dolutegravir resistance.
Yeah, just on that, I agree. There's one cohort study from Botswana, another study done now in Cape Town, which does show. Remember, when we talk about double dosing, it's actually not double dosing. It's twice daily dosing. It's giving the 50 milligrams twice a day. So it does look like that it's going to be okay. But I think we need bigger studies as well. There are documented cases of patients who get dolutegravir resistance with TB treatment from not giving it twice a day. So although in a controlled study, it seemed to be okay. I think we need more studies. But as Julia said, if it happens, and it is going to happen, that patients, are not given twice daily dosing, that at least we're pretty confident that for the vast majority of them, they will be okay.
Okay, thank you very much. I don't see any other questions, and I think we've also gone beyond 7 o'clock. So Dr. Marshall, you'll engage Dr. Levine or Dr. Tanner. We have to stop at the stage here. Sorry about that. Yeah, so just want to thank you very much, and Dr. Jan Levin and Dr. Julia Tena for your time and taking us through this journey on HIV management, the past, present, the future. And indeed, it's quite exciting times to see what's happening in the field of HIV management. And we just want to say, on behalf of Clinics Health Group, to thank you for your time, and also to thank our friend Papi, Dr. Majiba, for liaising with Right to Care to release you to come and share your thoughts and your knowledge and experiences and management of HIV in our settings, both in the public and the private sector. And I wish you all the best, Dr. Levin, as you embark in your journey at the Nelson Mandela Children's Hospital. We hope that we will be able to get both of you back sometime next year, not wait for the World AIDS Day for other discussions on management of HIV/AIDS. And also to thank all our colleagues who've joined us this evening. It's a pleasure to always welcome you every Thursday for these wonderful webinars that we are presenting with different speakers from different fields and healthcare management. And to also say thanks, Kamo, my background from marketing, and other colleagues who are working together with us. And we hope that we'll join us next week as we have the last session before the end of the year. And may you have a good evening and have a wonderful time till we meet again.
Thanks, Ryan. If we could just emphasize that, if people are welcome to phone our helpline. I am still at Right to Care as well as Nelson Mandela. They're welcome to phone our helpline. I'll put it on the chat as well. If they've got any questions about both adult or pediatric, the HIV, they're welcome to give us a call.
Okay, we'll put on the email also tomorrow when we do our...
Perfect.
Yeah, when we do the... Okay, thanks a lot. And say thanks to Ian.
Will do.
If you're still there, sure. Okay, thanks. Good night.
Thanks.
Sure.
Thank
Thanks,
you.
bye.
Bye.